Good morning. I'm Dr. Ramesh, General Secretary Associate Professor. Last time we had discussed about mediastinal injuries, in fact, chest injuries. Now it's time to discuss something about the mediastinum. And this topic, as such, you may not get a long question, but there are one or two potential short questions are there, either 4 marks format or 2 marks format. You kindly go through once the session is over, because this is a small topic only. So what is the mediastinum? You know that mediastinum is the central area which lies between the thoracic inlet and the outlet, that is the diaphragm. And that part which lies between the right and left pleura, and something that lies between the mediastinum and the vertebral column. So this mediastinum arbitrarily is divided into superior part and inferior part. And the inferior mediastinum once again divided into anterior mediastinum, middle mediastinum, and posterior mediastinum. There is, you should remember that there is no such gross anatomical division is there, but this is arbitrarily divided for our convenience, because in particular areas and particular foci, there are certain tumors which are more liaison is there for occurrence. Suppose we take superior mediastinum, you are likely to get thyroid and parathyroid in its extension to the system, mediastinum, apart from the lymphomas. And in anterior mediastinum, apart from the lymphomas, you are likely to get thymoma. And thymoma is very important, and it's in fact the most common primary mediastinal tumor that occurs in the anterior mediastinum. Whereas in the posterior mediastinum, you are likely to get some tumors which arise from either from the peripheral nervous system or from the sympathetic system. That means something like schwannomas or non-adrenal related pheochromocytomas, like neurogenic tumors. We will come to that point later. And in the middle mediastinum, we are likely to get something like pericardial cysts and mesenchymal tumors. Likewise, we will come one by one shortly. And this mediastinum surgical approach grossly is based on what structures you are dealing with, you are going to deal with. One is anatomical location of the tumor, whether it is superior mediastinum. Suppose you are dealing with the superior mediastinum, your approach is likely to be transcervical incision, plus or minus or with or without the help of median sternum. If you are dealing with something like anterior mediastinum, you have to cut open, lay open the sternum. That's not the good. That's you will deal with median sternotomy. Suppose you are dealing something with posterior mediastinum, you have to go for thoracotomy, lateral thoracotomy, with the help of sometimes with the help of VATS, that is video assisted thoracoscopic surgery. Especially if the tumors are small in size, they are supposedly non-malignant, you can develop VATS, that is video assisted thoracoscopic surgery. For structures which are located in the middle mediastinum, of course, thoracotomy is the option. So, what are the tumors of the mediastinum? Like any tumors anywhere, there are primary tumors are there, secondary tumors are there. In the primary tumors, most common is thymoma. Primary tumors can be thymomas or neurogenic tumors or lymphomas or lipomas can occur. But thymoma is the most important, and in fact, it is the most common primary tumor, which accounts for 25% of all the primary mediastinal tumors. Thymoma is the most common. And the importance of thymoma is that it can be associated with a neuromuscular condition which is famously known to you, that is nothing but myasthenia gravis. This particular neuromuscular condition is significant with relation to thymoma, because sometimes when a patient is having myasthenia gravis, it is likely to be improved when you remove thymus, even in the absence of a tumor in the thymus. So that is one correlation with myasthenia gravis. And second important factor is thymus, mostly though thymomas are benign, sometimes they may be associated with malignancy because of the various biological relation of the tumor that can be sometimes malignant, And the only potential for the malignancy can be known in case of thymomas by the capillary invasion, by the invasion of the capsule, by the invasion of the capsule. That's why we have to follow a staging called Masoka's staging in case of thymoma, MASOKA, Masoka thymoma staging, because most of the tumors, you know that we will follow TNM staging. The tumor size, lymph nodal status, and metastatic spread likewise. In this context, I would like to just mention about TNM staging. Sometimes it's confusing to the undergraduate level. We sometimes use us as TX or TIS because our topic is small, just I'm covering with something about TNM. Sometimes you call for each tumor, whether it is malignant or benign, for malignancy, TNM staging is used, and for each tumor, there is a specific TNM which is approved by the International Union of Cancer. That is, internationally acceptable classification for any malignancy is UICC. That is what we have to take in case of TNM. For each malignancy, there is a separate TNM system. In that also, if you use a word called T1 or T2 or T3 or T4 or sometimes, it depending on the size of the tumor, likewise N1, N0, N1, N2, likewise. Any status of 0 signifies that there is no involvement, right? Tx means that is tumor when it is not accessible, that is called Tx. Any non-accessible tumor, but still remind you there is cancer, there is malignancy, but you cannot assess the tumor, and sometimes they can be detected. Suppose if there is a carcinoma lung, hardly it can be detected when you are examining a sputum or you take a bronchial lotion, and then the malignant cells may be seen. Otherwise, it is negative either for the investigations and mm, also for imaging studies. Whether you take the flexible bronchoscopy, it will be negative. Cancer will be negative. Bronchus is free, lobar nose is free, lobus is free, everything is free. And if you say imagology like CT scan or MRI scan or PET scan, everything is negative. That means no mediastinal tumors, no tumor at all, and that is called TX. For any tumor, for any TNM classification, TX means tumor not assessed, whereas TIS means cancer in situ. TIS is particular cancers like breast or lung. We use TIS. That means cancer in situ. That means tumor is there, but it can hardly metastasis to distant metastasis is unlikely. Then you signify that you label as TIS. Whereas T1, depending on the tumor, sometimes, for example, if we are in the Mediastinal, you can say T1, like a tumor confined to the lobar lung, take a ipsilateral lung, and it is confined to the lobus. We can call it as T1, but not extending into the bronchi. We can call it as T1. Obviously, no extension to the carina, call it T1. Obviously, there is no involvement of the any macroscopic involvement is negative, you can call it as T1. But any tumor which extends in its greatest dimension up to 3 centimeters, call it T1. And again, you can go for subdivision T1A, T1B, T1, T2, likewise. T1A, 1B, 1C. Again, whether it is less than 1 centimeter, we call 1A, less than 1 to 2 centimeters, call 1B, or more than 2 centimeters, but less than 3 centimeters, we can call it T1C, likewise. But that is about T system. And sometimes we denote as P, small p, we denote it as P. That means you have obtained sample, tissue sample, and you have assessed the pathological. That means that staging is called P staging. If that is not done, you have to call it as C staging. That is clinical assessment. You take an X-ray, you take a CT scan, observe the patient, of course, obviously do all the investigations, but not pathological investigation. Then you call it as C. That is also CTNM or PTNM. Sometimes we denote a small letter called R. That is, that shows that it is some sort of residual tumor is there. Residual, sorry, smaller denotes that is a recurrent tumor. Recurrent tumor denoted as small r, whereas capital R sometimes is denoted where it is grossly residual tumor is present. After your dissection is over, some residual tumor is present. Sometimes we denote as Y. In case of TNM, capital Y we denote That means the treatment has been completed and the patient has been presented to you. Suppose the patient has undergone treatment somewhere else and he comes with records, and you have to now try to assess the patient, know whether to put in on the TX or proper staging. So he must be having his records must be showing by TL. Just for completion sake, I am telling you. But why I have told these points is, uh, in case of thymoma, we don't follow this TNM, but we follow it Masaoka's staging, and it is called stage one. When the tumor is well encapsulated macroscopically, and microscopically speaking, when there is no capsular invasion. And stage two, whenever the thymoma is there and it has extended into the surrounding fatty tissue or mediastinal flora, we call it as T2. And microscopically speaking, there may be invasion of the capsule. Any invasion of the capsular invasion goes to stage two. It is irrespective of the size of the tumor. And we call it as stage three whenever there is involvement of gross structures of the mediastinum, like pericardium, great vessels, or lung tissue proper. We call it as stage 3. And stage 4, again subdivided into 4A and 4B. 4A, we call it as whenever there is pericardial involvement, like pericardial effusion, or whenever there is pleural effusion. That means malignant pleural effusion, or malignant pericardial effusion. We call it as 4A. And 4B is something when it is lymphogenous or hematogenous spread is there, that is called distant metastasis, and you obviously label it as 4B. And again, important point to be remembered here is, of course, the patient has been presented with pleural effusion. You are thinking in terms of uh, thymoma, and if your exudate or if your pleural effusion is not exudative in nature, it is non-bloody in nature, that means no component of blood are there, and it is also negative for malignant cells. Then you have to definitely disregard this as criteria. It may be associated pleural effusion or pericardial effusion may be there, and it is unfair to label it as advanced tumor. And you have to go uh, according to the plan of treatment. And after thoroughly investigating, the management is obviously straight away. We can go for thoracic median sternotomy because it is situated in the anterior mediastinum. Sometimes, if it is definitive treatment is surgery only. Sometimes, if it is small, or if you are taking it for diagnostic purpose, or if you are taking it for the treatment of something like myasthenia gravis, uh, small thymus is there and there is no obvious thymoma, and then you can go for video assisted thoracoscopic surgery as well. And this is all about thymoma. And second thing is uh, something second, about 13 in 13% of cases we call it a germ cell tumors. Germ, germ cell tumors may be present. They account for nearly 13% as per the textbook, but you sometimes encounter the germ cell tumors. And this is anterior mediastinum again is the most common set of germ cell tumors, primary germ cell tumors. Anterior mediastinum is the most common set of primary germ cell tumors. Sorry, okay, okay. Coming to the topic, it is the anterior mediastinum is the most common set of extragonadal germ cell tumors. It accounts for maybe 13% of tumors, primary mediastinal tumors. And usually they contain all the elements from mesodermal or ectodermal or endodermal origin, and they mostly present in as cystic form or cystic swellings. That means consistency is cystic, and usually occurs in young adults. And 75% of these germ cell tumors, they are benign. They can attain huge size. They can cause compression, and in the by by getting extreme sizes, they can cause compression. And by the compressive symptoms, sometimes we have to relieve these symptoms and we have to go for surgery. But there is also one possibility that they can transform into malignancy. And in case of germ cell tumors, we do not follow any staging here, but we follow whether there is elevated levels of alpha fetoprotein or whether there are elevated levels of human chorionic gonadotropin, that is HCG. These tumor markers we follow, and if these tumor markers are elevated, then we can go for obvious treatment. And the treatment modality in case of germ cell tumors is particularly pertaining to chemotherapy. Once you have given chemotherapy, you have to follow up the patient by giving by, by following the patient approaches. We follow these. We follow this patient with tumor markers again, and if the tumor markers are normal and CT scan showing extensive tumor still, we go for surgery. Or if there is gross regression, of course we follow up the patient. And second possibility is there is persistence of the tumor and tumor markers have not been come to the normal level. Then there is no other goal, there is no plan for surgery. We can go for chemotherapy again and again. We have to follow whether the tumor markers have been normalized or not. In case of normalcy, getting tumor markers to the normalcy, then only you have to go for surgery. Otherwise, chemotherapy is the primary modality of the treatment in case of germ cell tumors. When I was telling about thymoma, surgery is the mainstay of the treatment. But in case of germ cell tumors, it is the chemotherapy that is the mainstay of treatment. And another important thing, that is the third point, is again primary mediastinal tumor, lymphoma can occur. These lymphomas are predominantly they develop in the anterior mediastinum. Though some literature says that they lie in the middle mediastinum, the majority of the literature goes in favor of anterior mediastinum. For that sake, lymphomas can occur in the superior mediastinum as well as anterior mediastinum, middle mediastinum also. Except in the posterior mediastinum, they can occur anywhere in the middle mediastinum, anterior mediastinum, superior mediastinum, likewise. But lymphomas are important for two purposes for us. One thing is they can attain a huge size, they can cause compressive symptoms, and sometimes to the extent that superior vena cava obstruction may develop. Whenever there is SVC obstruction is there, we have to treat the patient to get relief to get the relief from the SVC obstruction. Second thing is the lymph nodes. They are, as I mentioned earlier, majority of the components are the lymph nodes. They are primary lymph nodes either draining from the chest organs itself or sometimes secondaries in the mediastinum. They can pose some challenge by attaining huge size. So for that purpose also we have to assess sometimes only for diagnostic purpose only. We can go for mediastinoscopy. Mediastinoscopy. Sometimes by going through mediastinotomy as well. And the primary modality of treatment, there is again chemotherapy and radiotherapy only. Chemotherapy only. It is lymphomas are usually radioresistant. And again, we follow up the patient, and there is no role for surgery except for diagnostic purpose. And fourth point is sometimes you can encounter the huge thyroid or sometimes parathyroid tissue that can extend retrosternally into the superior mediastinum, the causing just huge sizes. They can compress the trachea, and the patient may be having sometimes hoarseness of the voice along with the stridor. By Lahey's method or these methods, you can do thyroid examination, right? But whenever there is compression, just use the lateral, that is Cocker's test, that is lateral compression of the thyroid. The lobes clinically produce stridor. In such patients, you have to go for surgery and remove the thyroid tissue. Usually the incision is transcervical incision. Sometimes, depending on the size, we can go for median sternotomy as well. For, sometimes we take the help of ads also, in case of retrosternal extension of thyroid as well. And another important thing is another kind of tumors is mesenchymal tumor. And predominant mesenchymal tumor, they are very rare in fact. But if at all it's there, sometimes in the posterior mediastinum they may be present, and sometimes in the middle mediastinum they may be present. And none other than lipoma is the most common. And whenever some mesenchymal tumors, and it's ectodermal or endodermal or mesodermal horizontal like glioma may be there, chondroma may be there, but they are very rare. But very rare. And fifth point is there may be neurogenic tumors. Neurogenic tumors, primary neurogenic tumors in the mediastinum. So these neurogenic tumors, we have to think of posterior mediastinum because the vertebral column and the sympathetic nervous system they lie in the posterior component, right? So in case of young patients, maybe neuroblastomas are common in case of children and young patients, whereas the schwannomas as well as neurofibromas, sometimes extraabdominal side of pheochromocytomas, they can occur in the posterior mediastinum and they can attain huge sizes because of the size and the compression symptoms, and sometimes local invasion like these, they need to be removed. And these one important thing here is most common extra-adrenal site for pheochromocytomas, which lie in the posterior mediastinum, is posterior mediastinum, that lies in the posterior mediastinum, and this classically produces, I can recall, the classic triad of pheochromocytoma that can arise even in the posterior mediastinal tumor, and that can classically present as patient presenting with headache, number one headache, number two is sweating, number three is palpitations. This is what's called classic triad of pheochromocytoma. I think one of our colleagues will deal with pheochromocytoma later on, but as the time is there, I am covering some part. So what happens with pheochromocytoma especially is it is technically difficult to suspect because we have to suspect this tumor, nature of the tumor, whenever you are having a tumor in the posterior mediastinum. In case of young patients, think of neuroblastoma. In case of adults, we think of schwannomas or neurofibromas or something like that. But whenever some patient has been undertaken for surgery, mind you, your induction by anesthesia can precipitate pheochromocytomas or certain drugs like opiates or metoclopramides, like these drugs, they certainly precipitate pheochromocytoma. So classically, the adrenal crisis will be there. Catecholamines will be excessively released into the circulation, and because of the hypertensive crisis, the patient presents with headache and sweating. The other classical other features may be present like weight loss or hyperglycemia or pallor. Likewise, but any patient presenting with these symptoms and suspecting of the pheochromocytoma, we search for adrenal gland. But that is negative means, and by incident, your CT scan or X-ray showing massive lesion in the posterior mediastinum, and you have to properly uh, assess the nature of the tumor. And the ideal treatment for this posterior mediastinal non-adrenal pheochromocytoma is subjecting the patient to a MIBG scan, that is giving beta-iodobenzyl guanidine dye and doing SPECT scan. Why this is important is because again contrast studies, by doing CT with contrast, that gives you excellent results. But the problem is contrast precipitates pheochromocytoma. So we best avoid giving contrast studies in mediastinal tumors, especially in the inferior mediastinal tumors. We don't go for CT as a first line of investigation. In fact, we can go for MRI, and if it is massive lesion is there in the posterior mediastinum, we go for MIBG scan with SPECT, that is single photon emission computerized tomography scan. SPECT scan we call it. That is the best thing to be done, and we can go for PET scan also by giving FE. I mean the tie is FDG we give like any PET scan, and in case in these particular tumors we can go for DOPA scanning also. but that is only for completion sake. We routinely follow MRI scan. MRI scan classically shows a Swiss cheese appearance. That's what is described. The Swiss cheese is nothing but a huge tumor. Space occupying lesion will be there, and something like a glass-like structure will be seen. That is classically described for this particular tumors. And second thing is these tumors, if you mention, it will be enough. Like thymoma, neurogenic tumors, lipomas, and just make a mention about pheochromocytoma as well. And another important thing is secondary tumors in the mediastinum. Secondaries can occur in the mediastinum and they can present as lymph nodal masses. And patient will be obviously having the primary malignancy symptoms of the primary malignancy, where from the primary has come, and very rarely we can go for surgery, and if at all we go for surgical treatment, that's only restricted for the diagnostic purpose only. And these are about the secondary tumors. Sometimes apart from these primary and secondary space occupying lesions in the mediastinum, there is also some tumors which can arise from the embryological origin. They are described as maybe thymic cysts may be there, bronchogenic cysts are there. Usually they are cystic in nature. There may be pleural cysts are there, pericardial cysts are there, or foregut cysts may be there. All these come as differential diagnosis, but their pattern is very, very rare. Occurrence is very, very rare. And this is something about mediastinal tumors. I think last time we have done with chest injuries, and this time mediastinal tumors. You should be thorough with thymoma. It may come as a sharp question for you, and I don't think remaining topic is okay. You go through, and anything else? Any doubts regarding this topic? Sir, no. Our respectable HOD is there. Dr. Subbarao sir is here. He wants to address you.
So good morning, dear students. I'm happy we are getting positive feedback from you all, and I hope all are following these classes regularly and then getting some useful information, tips, and subject. So as per our prior planning and also as per your request, I am planning to hold an assessment on the topics so far covered in online classes on 23rd, that is Saturday. So another 16 days later. So mostly it will be in MCQ form, and we may have some brief answer questions also. So I want to make it as brief as possible, maybe 1 hour, half an hour for MCQs, and another half an hour for the short answer questions. So the modalities we are working out, how it is possible, we'll think over and then do it. But definitely MCQ part, we want to hold it definitely. If the short notes form is not possible online, then what we can do is we can buy a notebook and then write in the notebook all the questions, and then you can submit them whenever you again attend personally to the classes. So that's in a nutshell what I want to inform you. Now, any further questions on this aspect or any of your suggestions, you are welcome. క్వశ్చన్స్ కూడా ఏమైనా వాళ్ళు అడుగుతారేమో. చెప్పాను అదే వెయిట్. నీ క్వశ్చన్ వచ్చింది. వై hexagonal germ cell tumor most commonly largest in the anterior mediastinum. చదువు నాదేమైనా వస్తే చెప్పాను.
It's actually one of the questions is why extragonadal germ cell tumors most commonly lodges in anterior mediastinum. The answer is simple, that it won't lodge in the anterior mediastinum. First of all, it is site for extragonadal cell tumors. The most common site is anterior mediastinum. That's nothing exciting, because extragonadal itself says that it is away from the gonad site, and gonadal germ cell tumors, they don't lodge into the superior mediastinum. It is the site for extragonadal germ cell tumors. Anything more? And our HOD sir has asked you and told you about examination, and those questions also can be typed here. Sir is here only, and if any suggestions or doubts, you can just put in the chat box.
వాళ్ళకి 16 days టైం ఉంటుంది కదా. నెక్స్ట్ వాళ్ళు ఎవరు?
Next period.
టీచర్ అంటే ఇప్పుడు ఇంకా టైం మిగిలిపోయింది కదా, ఇచ్చేసే. ఏం లేదు,
నేను ఇచ్చేసాను.